Dr. Lehrberger, what is the market potential for an implant like the OrthoGlide?
I think it's a great market potential, and I think it is increasing. According to the data that I have, at least regarding our country, Germany, which means 82 million inhabitants in 2010, we have knee implantation numbers of about 135,000 per year, and unicondylar knees of about 10,000, of more than 10,000 per year. And I would estimate that at least considerable part of the unicondylar knees could be replaced by the ABS.
Very good.
Implant.
What advantage does this product offer the patient?
According to my experience in surgery, it's a lot less surgery that needs to be done. I did this procedure also as an outpatient procedure, and the recovery is a lot faster than in a bicondylar knee or unicondylar knee replacement. So there are clear advantages in the procedure for the patient. And post-operatively, the weight bearing can be begun as tolerated just from day one after surgery.
Does the implant stay in place?
According to the experience that I had personally and also my colleagues, which should be together what I can say at least about 50 cases, I don't know of any one dislocation of the implant.
How difficult is the surgical procedure?
The surgery is, as any surgery, should be prepared well by studying the protocol, by observing one surgeon who has experience with the procedure, and to be aided for the first surgeries by someone who is experienced. If you regard this, I think it's a lot easier than a total knee or a unicondylar knee. A lot easier and a lot faster.
What is your own clinical experience with this product? Do patients get pain relief?
The patients get pain relief, but it should not be expected on day one. So I think one has to be a bit patient for the first weeks and tell this the patient well in advance before the surgery. Just to be patient the first weeks, and the pain relief can be expected after the first weeks.
What do you think is the mechanism of pain relief with this product?
Well, the question for me as a surgeon is not primarily, of course, the mechanism, but the success. I really don't know the exact mechanism of that. It might be a load distribution, a better load distribution, and also a slight improvement in the alignment of the leg that contributes to the success.
How do you manage patient expectations?
The patient expectations should be managed well in advance and before the surgery, of course, and I offer the patient to have this as an alternative to an implant like a unicondylar or a total knee, and I offer them this implant as also a preliminary procedure which might be changed or converted into a total knee, for instance, after several years. So the patient should be ready that it might be necessary after several years to have another surgery, but it can last for a long time to use, to work and to be able to have the ABS implant for this time.
Can this procedure be performed under local anesthesia?
Theoretically, I would say yes. Like an arthroscopy can be done under local anesthesia. I personally don't use local anesthesia for arthroscopy, and so I don't use local anesthesia for this procedure. Theoretically, I think it could be, but I personally never used local anesthesia.
What does the literature tell us about a metal surface articulating with the femur?
In this setting, I don't have any literature available. In my personal experience, I have used metal on cartilage, on localized repair of cartilage defects, replacing a local defect on the femur by a part which looks like a button and is screwed into the femur. So this part articulates as a metal with the cartilage of the tibia. And this, well, so this is just the experience. I don't have any literature available.
What is the ideal patient profile for this product?
Well, a good patient profile would be a sedentary patient who 60 or 65 years or older with a medial gonarthrosis, who failed to achieve all conservative measures that had been done prior to the procedure.